TopMedTalk.
Welcome to TopMedTalk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Stand by for a healthy conversation. But first, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. It is organised by iPoets, the International Perioperative Testing and Training Society. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org. And remember, this is an International Perioperative Testing and Training Society accredited event. So when you attend, you can get your iPoets accreditation showing that you are a practitioner who has reached a high standardized level of competence in performing and interpreting cardiopulmonary exercise testing for patients preparing for major surgery. Check out ebpom.org now.
Hello, welcome to TopMedTalk, and specifically TopMedTalk AI. This is our new monthly series, and I'm delighted to be joined again by my co-host, James Bowness.
Hi, Andy. How are you?
I'm good, thanks. Great to be here. We're in Scotland, St Andrews.
That's right.
And we're at quite a unique event, I have to say. I'm going to let you explain it more than me, because you know it better than me, but you showed me around this morning. It's a fantastic place and a fantastic course.
Yeah.
So why don't you tell listeners why we're here?
Yeah, sure. So I've got a long history at St Andrews, having previously studied here and been a staff member here and trained in Scotland for my clinical training. And at that time, a colleague and I, Ali Taylor, we developed a regional anaesthesia course here. There's a really excellent set of facilities, clinical facilities, cadaveric facilities, and we developed a course tailored around real ultrasound scanning of healthy volunteers using AI-Augmented Ultrasound imaging and augmented reality simulated needling on these real ultrasound synaloops, and then cadaveric ultrasound imaging with real needle insertion. And so we go through the Plan A blocks in regional anaesthesia in a very standardized formatted technique, but with a really excellent kind of rich teaching environment and kind of diverse experience. So there'll be more to follow on that in a future episode, we know, so I won't go into too much detail, but that's why we're here today, and it's a really excellent opportunity for us to gather some people who are interested in AI and perioperative medicine to have some of these conversations.
And we've got one of those fantastic guests with us now, so I'll ask him to introduce himself.
Hello, thank you very much for inviting me. I'm Dr. Bernard Delvaux. I'm a Belgian anesthesiologist, and I work now in France for more than 20 years. For 20 years exactly. I work in Quincy-sous-Sénart, which is close to Paris. It's a private hospital, and we do a lot of regional anesthesia, teaching, and also research in this subject. And I was especially involved last year in research in AI.
Bernard, tell us a bit about your background. How did you get into anaesthesia and then specifically regional anaesthesia, and then we can go into the AI components of that?
As far as I remember, regional anesthesia was always fascinating for me. Even when I was a trainee, I wanted to learn the most I could about the subject. At that time, it was neurostimulation. It was ultrasound guidance came right after when I went off to the school, and I learned it. I learned it with my colleagues where I work now, who were already very famous at that time for teaching.
Yeah. One of the things that drew me to regional anesthesia as a frustrated orthopedic surgeon was the practical application of the anatomy, and we'll get on to the AI and how that relates to that shortly. So regional anesthesia to me is living anatomy. It is
Yes.
true clinical anatomy. We're visualizing sonoanatomical structures in real time and then introducing an intervention that has a very predictable structural and functional change.
Yeah, obviously anatomy matters a lot actually, and you can do actually the more knowledge goes on and the more you take on this fantastic discovery about the 5-2 nerve block, for a tonsil surgery. It was published 2-3 years ago, and I was wondering why didn't we find out that 20 years ago? It is so simple. Actually, knowledge is there. It's very simple to do. Why didn't we think about it earlier? This is a very good example. Yeah,
it's practical application of pre-existing knowledge.
Yes.
Yeah. So getting on to the AI component then, for me, I found that getting into regional anesthesia, one of the real barriers was the acquisition and interpretation of optimal ultrasound images.
Yes.
And with the reduction of anatomy teachings in UK medical schools, anaesthetists who don't traditionally go into anaesthesia because they love anatomy, there are other things that draw them to that.
No.
But there is a limiting factor, barrier to the widespread delivery of regional anaesthesia, which we know is can be really good for patients.
Yeah.
So through conversation with some kind of research colleagues who said to me, well, we can identify 1 millimeter nodule on the prostate in an MRI scan. Like, surely you can see macroanatomical structure on ultrasound images. And that's kind of, with using AI. And that's what led me into this field.
Mm-hmm.
And so really it's a sort of technological extension of anatomy. So leading into then with AI and regional anesthesia, I know you've got a long background in developing these tools and being involved in these projects. Do you want to tell us a little bit about that?
Yeah, actually, General Electric Healthcare in France was looking for someone to help with the project of nerve recognition by AI, actually. And they reached out to my colleague, Dr. Mercadal, by the way. And he introduced me to the work. We've done this together. Actually, it was really fascinating because it was two words I'm meeting, the words of data scientist and the word of clinicians. And there were a lot of discussions, by the way, about, how to annotate. Do I take more? Do I take less? What should I choose? And actually, that's difficult to answer. So yes, the work was the annotation of data. A lot of data, a lot of annotation. It took years, actually. I spent years doing, those rounds or ellipses or shapes, to...
And by data, sorry, Bernard, we're talking about images off an ultrasound screen you're annotating.
Exactly.
So, and by annotating them, there's this overlay of colours that you're
Actually, the overlay is created by C-NERF, by the AI,
right.
and was doing, circle, just a line.
I see, yeah.
So to give a bit of background to some of the listeners, when you're training some of these deep learning models, two very kind of well-established techniques are supervised machine learning, where we will take an image of whatever it might be. It could be a regional anesthesia ultrasound image, it could be a picture of a cat, it could be whatever. You train the algorithm with that image and a label, and that label could be a tag which says it's a cat, or it could be an ultrasound image with a nerve on it, and the nerve could be drawn out or segmented.
Exactly.
And then you present the label and the image to the algorithm. You do that thousands, hundreds of thousands, or even millions of times, and the algorithm learns an association between the underlying image and the label. The unsupervised approach is that you can feed all that data in and then it can start to cluster things based on features within that data set, which we may or may not be familiar with, or may not cluster it in the same way. So Bernard, I think, is talking about that you collect a lot of ultrasound images, and then you, maybe colleagues as well, would annotate those images, draw around the nerves. Yeah. And then you'd use that to train
the annotator. Yes.
Yeah. Excellent.
But once you've annotated these images, what's the next stage and how do you use them into the model?
Actually, General Electric Healthcare had the data scientist to construct the models, so I was not involved in.
Sure. Okay.
Yeah. And so actually, it worked. Actually, they finally released a C-NERF that works only for 3 anatomical sites, but it works great, actually. Yeah. It is now replaced by nerve blocks, but for years, C-NERF has been working very well. And actually, it led to our first work together, James, because I remember this, this talk with the data scientist. He showed me the preliminary results, and he said, I said, well, this is a fantastic result. And he said, yeah, but the metric, the way when you apply formula to evaluate it are not that good. So this led to a work to the idea to compare objective and subjective metrics, actually. And it's very interesting field we probably will talk about later.
Absolutely, yeah. Yes. So for context, C-NERF is a tool produced by GE. Nerve blocks is a tool produced by a company called Smart Alpha, based in Turkey, with a partnership with GE. And of course, GE also own a tool that I worked on the development with, ScanNav Anatomy Peripheral Nerve Block. So there's a sort of confluence of interest within GE there on that. One of the things that I observed, which I think you're kind of alluding to there, Bernard, is that when we took these devices to regulators, the immediate reach was a technology objective pixel-based assessment. Take a still frame image, look at the nerve, how many pixels that the algorithm predicts overlaps with the pixels, that it is truly the nerve. And there are various ways to measure that. Some of the metrics are called things like dice metric or intersection over union. And I objected to that quite a bit because I said, well, actually, okay, there's a number of problems there. One is it's a still frame image. Ultrasound images refresh at 25, 30 frames a second, and we're scanning for 30 seconds. So which frame are we going to take? And it's really labor intensive, so you can't just do it for every frame. Similarly, if we take a frame and show it to 10 different anaesthetists, we're going to get 10 different annotations of where the nerve is, so who's right?
Exactly.
Yeah. And then thirdly, what's an adequate level of pixel overlap? Is it 50%? Is it all of them? And, because if we're putting a needle right next to where the nerve is, if the nerve, only half the nerve is correctly predicted, well, if it's in the half that isn't correctly predicted, that's a really big problem for us. So that's a really rich area of exploration, which I don't think it's certainly not fully resolved yet.
Yeah, actually, this is really interesting topic of research. Actually, we're still doing now. It moved, in my view, before we had clinical tools, the evaluation was only possible through objective metrics, those formula, because we only had this. But now there is a clinical implementation. The evaluation must be clinically oriented. Actually, you speak a lot about that, right? You wrote several articles about it.
That's right, yeah. One of the things about the objective pixel-based metrics is it's very granular, it's very detailed. You get kind of very fine-grained understanding, but it's incomplete. It doesn't provide a clinical picture.
Yeah.
You can also have a subjective, clinically based assessment where you say, show a cine loop of 30 seconds to a panel of 3 experts and ask them subjective questions. Say, does it identify the femoral nerve? Does it improve our recognition of the nerve? Is it safe? Those kind of things. And there's a lot of value in that, but there's not quite the granularity. So I think and I don't think we've fully understood exactly where it is yet, but there needs to be some kind of combined kind of approach there. I kind of developed a sort of methodology for that when I was doing some work to get a device approved in the USA for the FDA regulatory approval. And I think it's still imperfect. There's still a lot of kind of exploration, but it kind of serves to highlight for me a theme that our listeners are going to get very bored of, but that I really believe needs to be strong clinical leadership in healthcare AI, because if we had gone along with a pixel-based objective sort of metric of pixel overlap, then you could arbitrarily define what success and failure is. But what does that really mean clinically?
Well, that's what I was about to ask. So again, I should say I'm an enthusiastic amateur regional anaesthetist. I do a lot of my time in intensive care and I love regional anaesthesia, but I don't get as much exposure to it as I would like. But I can totally see how this sort of technology where the AI models on the screen are helping me deliver the block successfully could be game-changing. I get that. When you're developing these models and the techniques you're talking about and the assessment of it, is it anatomical specific? Are we just looking at femoral nerve blocks and then we look separately at a brachial plexus block and then separately at a forearm block? Are they all sort of developed and modelled and built up individually? And in which case, does it rely on the exact probe placement and in each case? And how do you standardise that going through the models? Because presumably, if I put a probe on your forearm, James, it might not be exactly the same place as if you put the probe on the forearm, Bernard, and that all needs to be factored into the model as well, doesn't it? And then...
Yeah.
Well, I think there are specific models for each regions in every software, right? In C-NERF, in nerve blocks.
Initially, that was the case. So that's how we developed. So C-NERF is built like that, and nerve blocks is built like that. That's how we originally built originally.
Yeah.
And then we moved to what we call an all-in-one model. So it would be a single model trained with all the data from all the anatomical regions. But that all those anatomical regions had labels attached specific to that region.
And by an all-in-one model, James, sorry, we're talking about the AI model. So
the AI model, which we would train a single model, which would include femoral data, axillary data, rectus sheath data, the whole lot. But there's some benefits to that because there's a bit of transferability. A nerve looks somewhat like a nerve in different areas of the body, so does a muscle and an artery. Yeah. So that can strengthen the model, because one of the challenges in training these models really successfully is showing it a diversity of the representative sample. Yeah. And if we just look at BMI 20, anatomically very standardized images, then that's not going to perform as well on someone with a different body habitus, with slightly atypical anatomy or previous surgery or something like that. And so that training over different areas certainly helps that diversity and strengthens the model. But you can also get some other advantages as well, because if you say, I'm going to do an auxiliary block, auxiliary level brachoplex block, and you click auxiliary level brachoplex on the screen, but you put it over the femoral region, if the model recognizes you're not in the auxiliary level brachioplexus, and it doesn't apply any color overlay. So we're kind of still at the very early stages of that, but I think they're, and the models approved and clinically available to this point have all been a separate model for different body regions. But I think we'll move to singular models which have more flexible applications, because that allows for things like potentially identification of the wrong sites block, maybe even wrong sides block in future if you're doing left versus right. And it provides opportunities to strengthen the model in different ways as well, because of just showing it different types of data.
And Ben, I can see you nodding. I mean, for the benefit of listeners that can't see and are only listening, you were nodding in agreement with James through that. But just to follow up on the diversity element, so when these models are built, I mean, are they built on young, fit 20-year-old men, or is it?
I actually the most varied and numerous data possible. Actually, the most the bigger the better. Well, so to speak. Yeah. That's how you can overcome the.
And can you give us some of our listeners some of the examples of the sort of numbers of cases that you're putting into these models, and I mean, not exact numbers, but as in the scale? Are we talking hundreds or thousands or hundreds of thousands?
Hundreds for sure, but hundreds of sequences. So which means on each sequence maybe 200 images. I annotated maybe 5 to 10, the most important one, and I think people filled in the blank for the intermediary. So it means maybe 300 sequences means 30, I don't know, do the math, 30,000.
A lot.
Yeah. But then if we're thinking about that, so the models that we trained on, we'd train it from up to about 100 people in each body region, sequence in each region. Each sequence might be up to a minute, 25 frames per second per minute. We're dealing with like hundreds of thousands to millions of images. So there's lots and lots of images going into the training there. And I think that's one of the benefits, again, of training with multiple body regions, because suddenly you've got multiples of that, and actually you've got really a vast increase in the data.
But it must be, to a significant extent, dependent on those baseline people. So no matter how many images you take from each screen region, if you're starting with 100 people, you're going to get a different set of images if you're starting with a different 100 people. So coming right back down to it, how did you pick those people? Who were those people? How varied were those people? Because again, as I said, my amateurish regional anaesthesia, the ones I struggle with are not the young, fit 30, 40-year-old people coming in after they've twisted their knee playing sport. It's the elderly with minimal muscle mass, or the obese with extra adiposity in the way. And so how does that feed into the model?
Well, the aim is to try and it's likely, not certain, but likely that your model will perform best if it's trained on data which reflects your intentional target population. So you can sort of crudely estimate what that would be by looking at population level data on the spread of BMI, on the spread of age. Those are the two biggest important determinants of characteristics of ultrasound appearance. But then increasing the volume as well as anatomical variance. And so you want to increase the volume of cases that you see so that you capture more and more of the anatomical variance. And those sort of atypical cases in machine learning, so we call them edge cases, the ones that are kind of occur at the edge of the bell-shaped distribution. And so by definition, the more data you get, the more likely you are to be able to have some of those cases in your sample.
So as these models evolve, Bernard, over time, do we keep adding to these data sets, or is it a case of once the model's been rolled out, it's a new model that has to come out to replace it, or how does that occur?
Actually, I was involved in C-NERF, in annotation of data for C-NERF, but not for the other models.
No, so but the C-NERF model, that was a combined, that was a defined data set. There was no once it's been released.
Actually, I was just the annotator.
Okay.
So I'm not aware of the entirety of the whole.
But you weren't. There's no way of sort of going back and annotating extra images to build into the model. There is, or
So you can, the model is trained to some extent on what it's got, but you can go and recruit additional data, add that to the pool of training data, and retrain the model on that additional data. So you
sort of like
continue to develop it.
Download a new update or whatever that your computer might do. Or
Yeah, exactly, yeah. But the one thing that's really interesting, I think, the thing for me is that, and regulators in the past have sort of taken this view as well, but with the new EU MDR rules, they're sort of placing more emphasis on where the training data comes from. For me, the thing that's interesting is actually the external validation data. Yep. Because really the thing that you're interested in is, does it work on your intended target population? That was my next question. Yeah. So we recruited a sample of people from our intended target population, tested on that. And for me, you could have trained it on flying pigs for all I care. If it works really well on the target population, then actually that's a more interesting finding, isn't it?
And I think that comes back to the assessment question that you're talking about. And again, I get the objectivity, the pixel assessment is one thing, but from a patient perspective, what they care about is having an effective block rather than exactly where the line is on the screen, surely. So how do we feed that into using these models?
It doesn't fit in the model. It's fit in the evaluation, in the clinical evaluation we do of the model. I think we speak about clinical utility. How does it help to orientate, where's the nerve? Oh, it's more, more superficial or deeper maybe. It may help for safety, maybe, all those sort of questions.
Can you tell us a bit more about that utility assessment and how it might be done? Or
Yes, actually, James, you introduced it. You proposed years ago an evaluation scale that included that notion of that there was segmentation part and the clinical utility part. And we went a little further lately together. Mm-hmm. Looking for the utility, clinical utility for orientation. And this was very interesting because we've seen, there are threshold of metrics. We use that to threshold of metrics, which means from the level of the metric considered good enough to guide the gesture. And the threshold was different for anesthesiologists or trainees, actually. So it means in general that the less experienced you are, the better the segmentation should be to be helpful. Imagine yourself being in a city, and if you don't know at all the city, you need a very good map, right? But if you know the city, maybe you just need some clues here and there, and you know your way. That's
a great analogy.
This is similar to that, I think.
Yeah. And I think that you raise a really good point there, Bernard, because there's a different utility to the different operators. I think what we're not trying to do here is take an expert like Bernard and say, we're going to make your blocks better or safer. The key thing here is that we know that less than 1 in 3 patients who may benefit from a peripheral nerve blockade are ever offered one. And I mean, that'll have been evident from your anaesthetic career. There'll have been people who are really pro blocks and people who just sort of think, well, we'll just do a tube and a bit of morphine. And so, but we know there are inherent benefits of regional anaesthesia. And my thoughts are kind of around this, is that this technology is about building out, democratizing patient access to the inherent benefits of those techniques, not improving an expert's performance, because the delivery is limited by the availability of an expert with the requisite skills and expertise. And if we can kind of provide some digital support to those competent but less experienced non-experts, then we can maybe facilitate the delivery to a wider population.
Which sounds fantastic, but I guess the obvious follow-on question to that, Bernard, is, are there any risks to using this?
Oh, I think so. Actually, this is what we're working on. Actually, how do we assess what those models do in a clinical-oriented way? Not only clinical orientation, but actually the do's and don'ts. And I think this is very important for this subject and others. I was talking about AI in POCUS yesterday at the ESRA webinar, and we was talking about ejection fraction in POCUS. Actually, it works if you acquire good images first. But if you don't know how to, and this is tricky, if you don't know how to acquire the images properly, all the subsequent analysis can be bad, actually. And it's very important to know also, you must have a certain level of training. You must know if you are able to use it or not in a safe way. That's very important.
So that's already becoming a common theme through these TopMedTalk AI episodes, isn't it? That rubbish in is rubbish out, regardless of what the AI does. You've got to have the...
Maybe because it's true.
Yeah.
And this brings me back to my regular kind of soapbox. The challenge in AI is not what's in for healthcare, is not what is technically possible, in my opinion.
Yes.
It's what's translatable, what's implementable safely, effectively, and what makes care better.
Yeah, indeed. And for me, actually, I would like to add an extra layer to that is the so-called psychological layer, because, acceptability, trust. Actually, you see people who have access to the tool and don't use it. Some are experts, probably they don't need it, and some are not, but yet they don't touch it. Actually, probably in the world of psychology, there are very interesting models that can help us to understand. Actually, they're already there and used a lot. For example, there's the auto-determination theory, who says that we have 3 basic psychological needs, including autonomy and competency. If those needs are threatened by the technology, that may be something that prevents people to adopt the technology. I think this is an important point of view too.
That's really interesting.
Yeah.
So really interesting. And it kind of makes me think a little bit. So you're right, the autonomy thing is important. And as physicians, as doctors, we like to think we make the decisions and it's really important what we do. But yet, interestingly, if we look at things in day-to-day life, some technology, I think if we had this discussion with a large number of people, a significant proportion would say, well, there's an element of this sort of autonomy issue with my phone, that it kind of picks up on things that I have and suddenly it's showing me adverts for whatever the conversation I was having over dinner last night or whatever it might be. How do you think that those technologies have kind of, not maybe overcome the barrier? I'm not sure that's the right word, but not kind of faced as much resistance, whereas in healthcare, we see this a lot. What's the difference between the consumer technologies, where that autonomy debate is there, but people still use the technology, whereas in healthcare, the autonomy debate is there, but perhaps they don't use the technology because they're really fixated on this autonomy?
I guess people in the common life who don't use the techniques, it's the same challenge. I think it's about the same challenge. A big difference I see in here is actually we need a lot of proof, we need a lot of science to endorse those stuff, and people often rely on this, or this not yet recommended, or maybe I can, keep my distance for now.
There's a higher threshold to overcome, perhaps.
Probably.
Yeah. Again, I don't know, but just thinking out loud, the 2 things that jump to mind to me listening are, one, the level of regulation in any medical device. And again, we can get your thoughts on that in a second, Bernard. And then I guess the second is there a learning curve or a wash-in period, a familiarity period that people need to go through to get comfortable with the new device in the medical world before they start using it in practice? Whereas in consumer world, it's there, it's in front of them. They, you have to buy the new iPhone because the other one stopped working, or you have to buy the new Android because they've taken away that
it's for the old platform.
Exactly. So they've forced you onto the new. Whereas in medicine, we're insisting we're competent on something and well trained on it before we roll it out. Which I'm not saying one is right or wrong, but that feels like a big difference to me.
Actually, I think this is something very important. We need training. We need a way to evaluate new devices in a fast and reliable way. And this is especially true with LLM, the large language model, ChatGPT, Claude, and the others. They are released one after the other very fast. And so it's like it's something new. We have to evaluate it again and again and again. We need a proper way, as doctors, as scientists, to evaluate them fast. And you know what to do when the new one comes out, and how we want to use it. And for that, we need guidance from our societies, scientific societies. We need help.
Well, that brings us perfectly on to your role as chair of the AI working group for the European Society of Regional Anaesthesia. Do you want to tell us a bit about that and where you see that going forward?
Yeah, I think what we need is literacy, and with doctors and actually even data scientists sometimes acknowledge that it's hard to keep up with everything that is coming. We are doctors. We need to know better how it works. Actually, think about CT scan or MRI. We don't need to be physicists to understand how it works. So we don't need to be a computer scientist to know how AI is applied to our field, but we must know what is, the important clues and important way to get insight.
And how to interpret it.
Yes,
Yeah.
yes,
So-
and the do's and don'ts, actually, the pitfalls and the strengths. This is literacy, and I think we need tools to evaluate.
So is that one of the priority areas that the European Society's working on then, try and help us with that literacy, or are there other things you're focusing on at the moment?
This is something I would like to implement the ESRA AI working group. I'm not speaking on behalf of the
Of course, yeah. And
ESRA.
any other sort of key focus areas that the group are discussing at the moment that you can give us a sneak preview of? Or
Well, it's a work in progress, but it's all about that, actually. Yeah.
So how could we go about then, improving AI literacy? There are various courses, and I'm sure we could all search online now and find a various course at different hospitals, university, which is a 1-day course or a 6-week course, but that is kind of struggling, I think, to transfer to the wider healthcare population. How do we
Yes.
kind of crack that nut?
Well, maybe you can help me, but I'm not aware of a very well-known, reliable source about this. And but actually, I'm reading here and there and listening everything I can. Actually, this is how I keep up with the information now. I think we definitely going to need that. Some sure spots we can get information from, but I think we're not yet there. For sure.
I think that's true. I mean, that's when I was kind of delivering the Royal College Anaesthetist Innovation Symposium last year. That was my main aim, was to sort of create that melting pot, that forum where we could all have that exchange of information. I don't think we've got that perfect place we all go to. Hopefully that could be TopMedTalk AI.
I was about to say, I think we're working on it, James.
Yeah.
We're trying to get there, but
Fantastic.
that's probably a good note to finish on. As always, you can find this and all our other TopMedTalk AI episodes on our website or on all the other main podcasters of choice. We're on Spotify, Apple Music, Amazon Audible. We're on them all. Do go back, look at the previous episodes, look out for our next episode. So this series is going to continue every month from now, and I really hope we will become that, or one of those definitive places that you can go to around the world and get your AI fix for perioperative medicine.
Well, that's certainly our aim, isn't it? That's what we talked about
Absolutely.
at the start.
So thank you for joining us. As always, we should thank our sponsors who keep us free and open access around the world. And this year, that's BD, Advanced Patient Monitoring, and GE Healthcare, without whom we couldn't keep bringing work like this. And we'll see you all next time.
Thanks, Bernard.
Thank you very much.
TopMedTalk.
And remember, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org.